Okay, and chamfer, one more question about chamfer that comes is, with the cavo surface it forms an obtuse angle, very important. Means if you have given a chamfer like this, cavo surface से ये वाला angle obtuse angle होता है. Shoulder is a 90-degree angle cavo surface से. Okay, remember one thing, that whenever we are giving an all ceramic crown, it should always be supported by a 90-degree butt joint. Now giving a shoulder, the advantage of giving a shoulder, it provides that circumferential, it provides a circumferential 360-degree band or a ledge that provides enough bulk to give the strength to the ceramic, to give enough strength to the ceramic, या फिर support to the ceramic, and also if it is in bulk it will be aesthetic, it will be aesthetic. तो ये बहुत बड़ी एडवांटेज है शोल्डर की. One major disadvantage of shoulder is that it has got inferior marginal adaptability. ये लिख लो, shoulder has got inferior marginal adaptability. Right? Radial shoulder is nothing but the internal line angle is rounded. Okay, never give a sloping shoulder. Sloping shoulder is basically 120 degree, rather than 90 degree it is 120 degrees. Never give any angles whenever you are giving all ceramic. It has to be a butt joint, remember this. It cannot, the sloping shoulder is a 120 degree slope. It is given in PFM. Okay, and so the best answer here is your shoulder. Feather edge you can give. Feather edge is a very indistinct margin. Okay, one more thing, shoulder is around 0.8 to 1 mm width, chamfer is around 0.5 mm width, and feather edge is around 0.3 mm in width. Remember this, right? Some more, right? Okay, so what are the indications of feather edge? Feather edge is a highly indistinct margin. So because it is indistinct, the technician can make it over contouring. Very important. The major disadvantage of a feather edge finish line is that the technician, because of its indistinct margin, he will try to compensate for it and will over contour it, right? The feather edge is given in cases of adolescent patients, जहाँ पे पल्प चैम्बर हाई होते हैं, in cases of tilted teeth on the side of the tail, so that we prepare less, where ideal chamfer cannot be given. Finish line in cementum, we do not want to prepare more on cementum, and where there is inaccessible areas, जहाँ पे बहुत inaccessible areas जैसे for example distal to 7, 8 etc. तो जहाँ पे दिख नहीं रहा है, accessibility कम है, there we can go ahead with the feather edge margin. I hope it is clear. What will be the ideal pontic design? Very important question. बहुत बार INICET, NEET बहुत बार क्वेश्चन पूछ रखा. Now we see a healing socket over here. So whenever you are seeing a healing socket, so the best answer is your ovate pontic. Ovate pontic. Okay, I'll show you the pics. The other choices are not they they are not correct, because conical pontic is given in knife edged ridges in case of posterior mandible, modified ridge lap. It is the most versatile pontic indicated mainly in cases of maxillary anteriors and posteriors and mandibular anteriors. Sanitary pontic always and always, you know, it is the most versatile. Modified ridge lap is the most versatile. अगर choices में if ovate is not given and if anterior पूछ रखा है, fresh extension socket नहीं है, there we can go ahead with the modified ridge lap designs. Sanitary always in posterior mandible, because for example if this is the case posterior mandible, तो हम अगर यहाँ pontic दे रहे हैं तो it will not touch the, अगर ये pontic है, there will be a 2 to 3 mm space beneath the pontic, so it may be biocompatible, patient can clean it, it may be hygienic, but it is not at all aesthetic. Sanitary pontic is not at all aesthetic. Ovate pontic is the best answer. It is the most aesthetic pontic in maxillary anterior region, especially in cases of fresh extraction sockets, right? So if you just want to remember this, if you can see it is a saddle pontic, we can see a space. अगर ये हमारा बक्कल है, एस्थेटिक है, ठीक है, फिर इससे जो उत्पन्न हुआ उसको बोले रिज लैप. रिज लैप ने पूरा कॉन्टैक्ट बनाया, एस्थेटिक था, बट अगेन इट वाज नॉट अ पॉइंट प्रेशर कॉन्टैक्ट. इससे सिर्फ एक पॉइंट कॉन्टैक्ट लेबियल टू द रिज था, ये सरफेस कॉन्वेक्स रही. मॉडिफाइड रिज लैप, टी शेप्ड कॉन्टैक्ट, मोस्ट वर्सेटाइल, ओवेट pontic, दिस इज द आंसर. सो द बेस्ट इज, तो होता क्या है कि जब सॉकेट जब हील होता है तो ऐसा लगता है, सो इट गिव्स द राइट डाउन, इट गिव्स द बेस्ट emergence profile. It gives the best emergence profile because the soft tissue heals around this conical pontic or heart-shaped pontic in cases of, as I told you, knife edge ridges, or spheroidal in cases of mandibular cases. That's it. Clear है? सैनिटरी या मॉडिफाइड सैनिटरी पॉन्टिक को छोड़ के सारे हमारे रिज को कांटेक्ट करते हैं, म्यूकोजल कॉन्टैक्टिंग पॉन्टिक होते हैं. क्लियर है? आई एम सॉरी, माई थ्रोट इज नॉट ओके, सो वट एवर आई कैन टीच यू. ओके, question number 3, which of the following is shown in the given image of teeth setting in an articulator? So if we can see, it looks like a complete denture. In protrusion, the teeth are looking edge to edge and the teeth are also contacting in the posterior region. So it looks like, I'm not showing the options right now, I'm just telling you that it's a case of balanced occlusion, where when the patient is protruding, the anterior teeth are contacting and at the same time the posterior teeth are also contacting. So it's a case of bilateral balanced occlusion when the patient is protruding. So let us see the options. Unilateral groove function, no. It is in natural teeth where the teeth contacts canine and the premolars and maybe the mesiobuccal cusp of the first molar on the working side. Balanced occlusion with posterior teeth in contact during protrusion. Unilateral canine guided, bilateral canine guided. So in denture it cannot be a canine guided occlusion. The teeth are contacting. The canine guided occlusion is always a unilateral. Why? Because see, unilateral groove function, it is again in natural dentition. That is on the working side. The teeth contacts canine, first premolar, second premolar, okay, and maybe the mesibuccal cusp only on the working side, and on the non-working side it is disclusion, nothing contacts. This is the right answer that I've told you. Canine guided on the working side, only the canine tips tip contacts, okay, and nothing contacts elsewhere. That means distal to canine, even on the working side nothing contacts, non-working side पे तो कुछ contact होगा ही नहीं, ठीक है. So the best answer here is your balanced occlusion with posterior teeth in contact during protrusion. Okay, clear है. तो just थोड़ी चीज़ और बताया तो in the balanced occlusion we have condylar guidance, incisal guidance at one side, that are enemies of balanced occlusion, that will create disocclusion, and we have friends of balanced occlusion that will help in maintaining contact, that is compensatory curves, cuspal height and angulation, and plane of orientation या plane of occlusion. तो compensatory curves को prominent करोगे for balanced occlusion, cuspal height and angulation को बढ़ाओगे, plane of orientation को भी आप change कर सकते हो, but it should be the last factor, not more than 10 degrees. More the condylar guidance of the patient, it is not in the hand of dentist. If it is more, there will be more disclusion, difficult to do balance. Incisal guidance या anterior guidance, it is in your hand. Yes, somebody is asking, in natural dentition have canine guided? Yes, it is the best occlusion, especially in young adolescent patient with the canine tips still very sharp. They have canine guided occlusion. It's a best occlusion, no doubt about it. Especially when you are giving posterior ceramic, all ceramic restoration, it is always best to have canine guided occlusion. I hope I am clear. Clear? Right? So incisal guidance, keep it as less as possible. It is in your hands. Condylar guidance is patient derived fact. It is not in your hands. And condylar guidance, you can achieve it but with the help of protrusive record. Remember this. You can get the condylar guidance of the patient by taking a protrusive record. You can, program the articulator and can get the condylar guidance of both the sides. Right? Anterior guidance should be as less as possible, ideally 0. Keep very less overjet, overbite. Keep very less overjet, overbite. For balanced occlusion, because we do not want any inclines. Even if we get a more of anterior guidance, there will be inclines and there will be lot of disocclusion posteriorly. No, 9. फोन तो उठाओ. Sorry. Next question. Guide planes which are used in the fabrication of RPDs serves the purpose of, it determines the amount of retention in RPD, it helps in predictable clasp retention, It is required for precision attachment. It is perpendicular to the occlusal plane. Okay, so the best answer is, it has come so many times, it helps in predictable clasp retention. Why? Okay, guide planes, just a minute. Okay, so guide planes are used in the fabrication of RPDs. They serve the purpose of, so guide planes, it helps in predictable clasp retention, is the best option. Why? Now if you see this, so when we are, ये हमारा convex to surfaces होते हैं हमारे, right? So RPD has to go between the two proximal surfaces, parietal surfaces. So we have to make this surface parallel to each other. So these are basically 2 to 3 parallel vertical surfaces that we need to create parallel, so that you have a single path of insertion of the RPD, right? Okay, so now they help in providing that single path of insertion or predictable path of insertion. Now if the RPD sits completely, so that means every component, if it sits completely, if it is completely seated, that means every component in its right place. So when the every component in right place, that means the clasp will definitely be below the height of contour. That's what we want. We want the clasp tip to be below the height of contour. If because of this guide plane we are able to seat the RPD completely, and when the RPD is seated completely, the clasp tip would go below the height of contour and will definitely produce the desired retention. So it will help in predictable clasp retention. Other thing is that it also produces passive retention. This is important. See, ideally in a cast partial denture, the retention can only be provided by the the direct retainer or the extracorneal clasps or the attachments. Okay, but passive retention can be provided by the contact of the guide plane with the guide plate. So it is basically the resistant to deformation of the metal with the teeth surface sliding against each other. Okay, it also provides stability. It also provides stability. It also provides stability. It also provides stability, passive retention. Okay, predictable clasp retention, and also very important is that you can insert and remove the cast partial denture without undue forces on the abutment. Very, very important points that I am telling you this. Right? Clear है? ठीक है? So the order of producing is that सबसे पहले आप guide plane बनाएंगे, उसके बाद आप rest seat बनाएंगे. Never do it उल्टा. Why? Because अगर आपने पहले rest seat बना दी, फिर उसके बाद आप guide plane आप बना रहे हो as a mouth preparation procedure, the dimensions of the rest seat might change. Okay? Next, true for curve of Wilson. It is an anterior posterior curve. No, the anterior posterior curve is curve of Spee. It helps in the posterior teeth arrangement and lateral balance. Yes, this is the correct answer. Can you determine the posterior occlusion? Posterior occlusion will be ठीक है, maybe not. Cusp touching all the teeth towards the anterior border of the ramus. No. The best answer here is it helps in posterior teeth arrangement and lateral balance. The best answer. देखो, जब हम कॉम्पनसेटरी कर्व्स की बात करते हैं तो कॉम्पनसेटरी कर्व्स हमारे हम कभी भी दांत को एक ही लाइन में फ्लैट नहीं लगाते. हम उसको हम कॉम्पनसेटरी कर्व्स में लगाते हैं. सो वी एक्चुअली एग्जैजरेट द कॉम्पनसेटरी कर्व्स. अब चाहे वो हमारा कर्व ऑफ स्पी हो या हमारा कर्व ऑफ विल्सन हो या कर्व ऑफ मॉनसून, दैट इज द कॉम्बिनेशन ऑफ ऑल द कर्व्स. कर्व ऑफ सी हमारा स्टार्ट होता है टिप ऑफ द कैनाइन टू द बक्कल टिप ऑफ द मैंडिबुलर टीथ एंड गोइंग टुवर्ड्स द रेमस. ओके, राइट. कर्व ऑफ विल्सन, इफ यू सी दिस, it touches the cusp tip of buccal cusp tip, then the palatal cusp tip, then again the buccal. So it's a transverse curve, it's a mediolateral curve. Both curve of Wilson and curve of Monsoon, these are the mediolateral or the transverse curves that helps in producing. So curve of C produces the protrusive balance, or curve of Wilson and curve of Monsoon produces the lateral balance. Produces the lateral balance. So curve of Wilson for maxilla is convex downwards. And for mandible, see, it is because of the buccal tilt of the maxillary cusp. Because of the buccal tilt, the palatal cusp comes closer to the glass plate and the buccal cusp are above. That's why it is convex downwards, and it is concave. It is meant to be concave for mandibular teeth. And curve of Monsoon is a combination of all the curves where it forms a whole circle with the radii of 4 inches, the total diameter of 8 inches, and with the center at glabella. Okay, it might be as a very theoretical question. Okay, so the curve of Wilson, it is convex in maxilla and concave in mandibular arch. Okay, right. The curve of Spee is resultant of the axial inclination of the teeth. Okay, right. And when we are talking about the curve of Wilson, it is basically हमारे जो मैग्जिल दांत होते हैं वो हमारे बक्कल टिल्ट हो जाते हैं तो पैलेटल कस नीचे आ जाते हैं. That's why it is convex for maxillary and concave for mandibular, right. Okay, the concentration for aluminium chloride, this is aluminum chloride, sorry, in retraction cord solution, yeah, gingival retraction solution is, see, it varies from 5 to 25% mainly, लेकिन in most of the cases it is around 5 to 10%. So here the best answer is 5%. Remember this. अगर आपसे रेंज पूछी जाती है, एल्यूमिनियम क्लोराइड इज द मोस्ट कॉमन रिट्रैक्शन कॉर्ड सॉल्यूशन. ठीक है, देखो और कौन से हैं. वी कैन हैव एलम, दैट इज एल्यूमिनियम, पोटेशियम, फॉस्फेट, that may come in 10% and 100% concentration. We can have epinephrine, we can have racemic epinephrine 8% and 0.8% racemic epinephrine. So these epinephrine are not to be used, these are vasoconstrictors, not to be used in cases of hyperthyroid and cardiovascular diseases patients. Okay, then we have your, I've told you aluminum chloride, the most commonly used solution. Then we can have ferric sulfate around 15 to 25% solution. एंड एक सिस्टम आता है हमारा डेंटो इन्फ्यूजर सिस्टम, उसमें यूज होता है डेंटो इन्फ्यूजर सिस्टम. So the concentration of aluminum chloride, it is aluminum chloride. Okay, I'll just change this. Okay, as a retraction cord solution. Okay, okay, ठीक है. और भी मेटाजोलिन, योर नेगेटॉल, जिंक क्लोराइड इज नॉट यूज नाउ इट इज बिकॉज सो इट्स अ ये हमारा इट्स अ पार्ट ऑफ. देखो 3 तरीके की रिट्रैक्शन होती है हमारी, ठीक है. पहले होती है मैकेनिकल, फिर होती है कीमो मैकेनिकल, तीसरी होती है हमारी सर्जिकल. सर्जिकल में हमारे 2 आ जाते हैं, इलेक्ट्रोकॉटरी, ये इलेक्ट्रो सर्जरी, और दूसरा आता है रोटरी क्यूरिटाज. रोटरी क्यूरिटाज, और जिसको हम बोलते हैं जिंजिटाज. ओके, सो द बेस्ट, इफ समबडी आस्क्स यू व्हिच इज द बेस्ट मेथड, इज अ केमिको मैकेनिकल. वाई? देखो हमारे 2 मेन पर्पस होते हैं जिंजाइवल रिट्रैक्शन के. 1, फिजिकली डिस्प्लेसमेंट ऑफ द जिंजिवा अवे फ्रॉम द मार्जिन, सब जिंजाइवल मार्जिन, and at the same time also produce hemostasis. We need a clean field so that our rubber base can come, because most of the rubber base are hydrophobic in nature except your polyethers, so they will not be able to record that well. We need to create their space by mechanically separating the gingiva first and also reducing, and we want a clean field. So that is why, for example, if we are to use with the retraction cord, we have to soak it in a gingival retraction cord solution to achieve chemo-mechanical method, chemico-mechanical method, yeah, no. So दोनों का combination is the best. Rotary curettage gingitage is an intentional, we just place the burr inside the sulcus to remove the epithelium. Again, electrosurgery will, you use a fully modulated current that will produce a current that will volatilize the soft tissues around the sulcus, create space. Okay, so we can use all this, but the best system for gingival retraction is your chemo-mechanical method, right? We can use single cord technique, double cord technique, whatever you want to use, you can use. Okay, okay, we have an old CD wearer, question number 8, and the habit of chewing the front teeth. Okay, what will be the effect? Loss of stability of the denture, yes, it may happen. So A may be the choice, but let us see. Flabby anterior tissue, soft tissue after long term use, this is even more correct. Atrophy of posterior ridge, no. Atrophy of anterior ridge, yes. Atrophy मतलब residual ridge resorption हो सकती है, बट सबसे इम्पॉर्टेंट और जो फाइनल लॉन्ग टर्म यूज़ में जो होगा वो यही होगा कि हमारी रेजिडुअल रिज रिजॉर्प्शन. ओके, बिकॉज देयर आर कांस्टेंट इंसाइजिंग फोर्सेस. देखो इसमें 3-4 आंसर हो सकते हैं इस क्वेश्चन में. बिकॉज ऑफ फ्रीक्वेंट इंसाइजिंग देयर कैन बी अ लॉस ऑफ स्टेबिलिटी ऑफ द डेंचर, बट इंसाइजिंग विल एक्टिवेट द PPS. इट माइट नॉट बी, stability can still be there, right? लेकिन constantly अगर patient anterior teeth से खा रहा है तो होगा क्या? There is a lot of overuse. Rather than disuse atrophy, it is basically overuse of the anterior teeth. तो वहाँ पे प्री मैक्सिला में हिट हो रहा होगा. There will be loss of bone anteriorly in the premaxilla that will finally lead to flabby or redundant or hypermobile tissue. Mind you, maxillary anterior is the most common site of flabby tissue formation. लिख लो. और यहाँ पे जो आप either you will use a window technique, either you will use a window technique of impression, okay, where for example जैसे मान लीजिए ये तुम्हारा मैक्सिलरी रिज है और यहाँ पे तुम्हारा रिडंडेंट टिश्यू है, तो इसके अलावा इसको छोड़ के आप सारा, फॉर एग्जांपल आपने ZOE से ले लिया इम्प्रेशन और यहाँ विंडो बना रखी है आपने ट्रे में, यहाँ पे ये, ठीक है, फिर आप दोबारा रखो ट्रे को एंड देन यू अप्लाई either very mucostatic material over this flabby ridge so that you can record it in mucostatic in rest, okay, with the help of either POP or light body, because we do not want to create any stress, we do not want to displace this tissue because it will not provide it is poor in support. Your flabby tissue, write down, it is provides poor support. So एक और बहुत इंपॉर्टेंट क्वेश्चन आता है कि फ्लैबी टिश्यू में शुड देयर बी अ इंटीमेट कॉन्टैक्ट of the tray with the flabby tissue, or should there be an intimate contact of the impression material with the flabby tissue? So the best answer is intimate contact of the impression material with the flabby tissue. Tray intimate contact कभी नहीं करेगी वहाँ पे, because as you all know, for example buccal shelf area है जो कि stress bearing area है, वहाँ पे हम spacer नहीं लगाते ताकि tray can have a direct contact over that. So tray will always have an intimate contact with the tissues that are supporting areas, but the tissues that cannot support, they will be recorded in under mucostatic impression with the mucostatic material like window technique, or we can create some excess holes, lot of holes, so that no development of hydrostatic pressure takes place, so we can use that technique. I hope it is clear. Next question. Edentulous patient has arrived at the dental clinic for complete denture. Which of the following is not affected by the period of edentulousness? Residual resorption, it may be more when the period of edentulousness increases, yes. Tongue size, definitely, it may, there is a pseudo increase in the size of the tongue. Long-term edentulousness increases, the tongue spreads laterally. Does the patient attitude towards the denture, let us see, and patient adaptation to CD? देखो, yes, it may affect. Long-term edentulous can affect the patient adaptation to CD, but attitude जो patient का है वो हमेशा वही रहेगा, चाहे patient आज denture बनवा ले, चाहे 20 साल के बाद बनवाए. तो सबसे कम जो कि affect होगा वो patient का attitude होगा. अब इसमें कुछ चीज़ें देख लेते हैं. If we talk about the tongue size, we can have a normal tongue size, that is normal in developmental function, and to maintain the tongue size we have sufficient teeth, so it is class 1 normal tongue. Then there is atrophied tongue, okay, जहाँ पे जो teeth हैं वो कुछ लंबे समय के लिए they are gone, that can lead to some change in the morphology of the tongue function and the form. Tongue may become flattened and broadened. If all the teeth have been absent for long period, it may lead to abnormal development and pseudo increase in size, that is hypertrophic tongue. Now in such a tongue, that is class 3, that is excessively large tongue, it is very, very difficult to make a denture, so it causes poor prognosis. So this is regarding the tongue size. Now let us talk about the tongue position. The tongue position classification was given by Wright, in which again he classified the tongue position that is being seated in the floor of the mouth into three types: class 1, class 2, class 3. Class 1 is normal, where the tongue tip lies in the floor of the mouth with the tongue forward, tip forward and slightly below the incisal edges. For example, ये हमारे अगर दांत है तो हमारी टंग टिप it is slightly below the incisal edges of the anterior teeth. Okay, the floor of the mouth is not visible. Class 2, because of the absence of the teeth, the tongue position might be flattened and broadened, okay, but the tongue tip or tongue is still in normal position. Class 3, again it's the worst condition or the poor prognosis case. Why? Okay, tongue जो हो जाती है वो you may see some patients who have a retracted tongue. The body, the tip gets assimilated in the body of the tongue. There is no tip. The tongue is curled upwards and downwards, and the patient, when he opens the mouth, he retracts the tongue, and the lingual seal, alveolingual seal cannot be formed. तो ऐसे में अगर कोई आपसे क्वेश्चन पूछता है, ये क्वेश्चन आया हुआ है, तो ऑन द लिंगुअल एस्पेक्ट, लिंगुअल फ्लेंच, यू गिव अ ट्रेनिंग ग्रूव. एक एल्वेोलर ग्रूव या ट्रेनिंग ग्रूव देते हैं ऑन द लिंगुअल फ्लेंच, एंड वी आस्क द पेशेंट, क्योंकि पेशेंट की टंग तो पीछे, तो हम पेशेंट को कॉन्शियसली बोलते हैं इस ग्रूव को टच करने के लिए, तो उससे टंग कॉन्शियसली थोड़ी फॉरवर्ड पोजीशन में रहती है. तो ये क्वेश्चन आया हुआ है कि अगर पेशेंट की टंग क्लास 3 पोजीशन में है, क्लास 3 उसमें है, तो आप एक लिंगुअल ट्रेनिंग ग्रूव लिख लो. ये कहीं मिलेगा नहीं आपको. लिंगुअल ट्रेनिंग ग्रूव आप दे देते हैं. Patient tongue will constantly or consciously touch that groove so that it remains in a forward position rather than a retracted position, and thus improving the prognosis of a denture. Otherwise denture will come out if there is no seal, right? And regarding the 4 categories, House categories, philosophical, we know we have a reasonable, calm, very friendly patient. He understands the treatment, understands the best patient to have, and willing to follow all the instructions. The prognosis is excellent. Second is exacting, class 2. They are intelligent, methodical, but highly precise. They are excessively demanding. They need to be convinced for the patient, the need for the treatment, but you need to be more patient and attentive to the patient demands. But yes, once you have did a good job, so still the prognosis can be good to fair. These are the worst patient, hysterical patient. These are emotionally unstable. They may be happy at one time, they may cry at other time, they may have a negative attitude, unrealistic expectation, poor. They are poor adaptive patients, horrible prognosis. Then we have indifferent. That means indifferent patients are highly uninterested, they are apathetic, unmotivated. मतलब खुद नहीं आएंगे, किसी बोलेंगे जी हमें तो कोई फ़र्क नहीं पड़ता जी, हम तो वैसे भी खा रहे थे, हम तो ऐसे ही आ गए, हम तो वैसे भी ठीक थे, we were still eating, somebody have sent me, I have not come. So they are very difficult to motivate, but still they are not concerned about their oral health. They have been initially treated with so many dentists, so they don't, they are very indifferent towards their oral health. The prognosis is just okay. Okay, next question. When preparing a partial veneer crown on a maxillary premolar, the proximal grooves should be, now it is a partial veneer crown, remember this. Whenever we are giving a groove, for example in a full veneer, it should be again parallel to the long axis of the crown. Whenever we are giving a partial veneer crown, again the groove has to be parallel to the long axis. So the best answer here is, when we are giving either a full veneer crown or a partial veneer crown in posterior teeth, it has to be parallel, right down, it has to be parallel to the long axis of the teeth. When we are giving a partial veneer crown, in an anterior teeth, this is anterior teeth, so it has to be parallel to the incisal 2/3 of the labial aspect of the crown structure. तो ये अगर हमारा है तो नॉट जिंजाइवा से पैरेलल नहीं होना चाहिए, ये ग्रूव जो पैरेलल है ये आपका इससे पैरेलल होना चाहिए, इतने एरिया से, इंसाइजल 2/3 ऑफ द लेबियल सरफेस फॉर एंटीरियर 2/3, एंटीरियर पार्शियल वेनियर क्राउन या एंटीरियर 3/4 क्राउन. पोस्टीरियर वेनियर, अगेन आई एम सेइंग पोस्टीरियर वेनियर क्राउन एंड posterior full veneer crown or posterior partial veneer crown parallel to long axis of the teeth, but when we are going for anterior, then it has to be parallel to the incisal 2/3 of the labial aspect of the crown, then only it can be seated well. Okay, next question, identify the prosthesis. See, this was the initial figure that came in the examination. So this is basically, you can see, so I have brought you a more fairer picture. You can see a tooth, you can see a ball or a stud attachment, so it's a tooth supported overdenture. You have saved canines, so it's a tooth supported overdenture, okay, with an attachment or a stud attachment. Okay, so you can see the male portion, this is a tooth supported, where they are prefabricated. You make a space up with a piezo reamer for the attachment. It is cemented in the tooth structure and we have a female portion in the denture, so touch button की तरह बैठ जाते हैं. And this I have brought a picture. This is again a tooth supported overdenture but bar and clip type. So if this can be asked, this can always be asked. So we have a clips that are in the denture, a bar that is being cemented on the teeth. So this is given when you for example when the abutments of overdenture abutments have poor periodontal health. So in such case they will have a splinting effect. Okay, अगर नॉर्मल कोपिंग हो तो नॉर्मल कोपिंग वाला है. देखो अगर इसमें ये ना हो और उसको कोपिंग दिख रही हो तो नॉर्मल कोपिंग सपोर्टेड ओवरडेंचर, राइट, नॉर्मल ओवरडेंचर. ओके, ओवरडेंचर हैव the main purpose is preserve the alveolar bone. Definitely they will increase the masticatory efficiency, definitely retention, stability, support सब increase होता है ओवरडेंचर से. ओके, प्रोप्रिसेप्शन, मैंडिबुलर मूवमेंट इंक्रीज होते हैं. ठीक है, पेशेंट साइकोलॉजी के, पेशेंट के दांत बचा लिए आपने. बेस्ट इज बायलैटरल कैनाइंस, बेस्ट अबटमेंट्स बायलैटरल कैनाइंस प्लस सेकंड प्रीमोलर्स बोथ द साइड्स. अदरवाइज एटलीस्ट बायलैटरल कैनाइंस होने चाहिए. अगर ये मत करना कि एक साइड का मोलर ले लिया, एक साइड का सेंट्रल इंसाइजर. नो, वी टेंड टू use abutments in the interforaminal region. Why? Because especially for mandible, because anterior mandible is prone for resorption 4 times as compared to your anterior maxilla. That is why you do more cases of overdenture in case of mandible as compared to maxilla, right? So what is this? This is if you see, this is a cast partial denture technique known as your corrected cast or the altered cast technique. Okay, it is again done to combine the anatomic impression of the teeth with the functional impression of the ridge. It's a laboratory way of doing it. So when these both can be combined, this is an altered cast technique. हम इसमें क्या करते हैं, हमने पेशेंट का नॉर्मल, हमने फाइनल इंप्रेशन ले लिया आफ्टर माउथ प्रिपरेशन. ओके, नाउ व्हाट वी डू इज, हमने जो फ्रेमवर्क था हमने मास्टर कास्ट पे बिठा दिया, हमने ट्रे बना दी, बॉटम मोल्डिंग कर दी, फाइनल इंप्रेशन ले लिया, एंड वी ट्राइड एंड वी रिमूव द इडेंचुलस पार्ट फ्रॉम बोथ द साइड्स. We put the framework with the impression on the cast where the edentulous areas have been removed. We do the beading on the boxing and pour this. If we pour this, जो कि functional impression है, तो basically हमने anatomic portion को हमने functional portion से जोड़ दिया. तो कौन सी cast technique है हमारी? This is basically a corrected cast or the altered cast technique, right? For cast partial dentures, again done in distal extension cases to have the equal support from the ridge as well as from the abutment. Okay, a patient with severely extruded molar reported to the dentist, and on the removal this will create a distal extension case. What could be the best treatment plan? देखो, अगर दे रखा हो कि 1 या 2 mm ही सुपर एरप्टेड है, 1 या 2 mm 3 mm तो सुपर एरप्टेड है, स्टिल यू कैन सेव द टीथ बाय डूइंग अ रूट कनाल. ऑलवेज अगर ये मान लो ये एंटीरियर टीथ प्रेजेंट है और पोस्ट ये इडेंचुलर स्पेस और लास्ट के दांत हमारे सुपर एरप्टेड हैं, है ना, ये प्लेन से हमारा ये प्लेन था इतना सुपर एरप्ट हो गया, अगर हमारी कुछ थोड़ी सुपर एरप्शन है तो यू कैन स्टिल always try to maintain a tooth supported situation rather than creating a distal extension one. Remember this, because a tooth supported situation is always better. Never try to convert a tooth supported situation in a distal extension one. That is a more difficult to control because there will be lot of fulcrum, lot of movement. It's difficult to control, simple है. लेकिन इसमें दे नहीं रखा कि कितना एक्सट्रूड. अगर सीवियर एक्सट्रूजन है इसका मतलब प्रोग्नोसिस पुअर है, बेस्ट यू शुड एक्सट्रैक्ट द टीथ. वी कैन नॉट डू वेल. बट अगर दे रखा हो 2 से 3 mm एक्सट्रूजन है तो डेफिनेटली आप इंटेंशनल रूट कनाल करो, मेटल कोपिंग से आप यू कैन करेक्ट द प्लेन, यूज दैट टीथ फॉर सपोर्ट ऑफ अ डिस्टल एक्सटेंशन एंड ट्राई टू मेंटेन द टूथ सपोर्ट एज कंपेयर टू द डिस्टल एक्सटेंशन, राइट. सो अगर ये आप अगर देख पा रहे हैं फॉर एग्जाम्पल, ठीक है, तो इस केस में इतना सीवियर सुपर एरप्शन है तो आप उसे निकालोगे ही ना, बचा के क्या करोगे, ठीक है. Clasp indicated to engage the distobuccal undercut adjacent to the distal extension space. So the best answer here is your reverse circlet clasp. कैसे? Remember one thing, you have two situations in a tooth supported and we have your distal extension. So in a tooth supported, you give rest adjacent to the adjacent teeth, and always remember that you engage the undercut that is away from the ये edentulous ridge है, तो आप हमेशा undercut that is far away from the edentulous ridge that is in the far zone. तो ये वाला क्लास जो tooth support situation में आप देते हो, it is simple circlet clasp. So अगर क्वेश्चन पूछे आपसे कि simple circlet clasp engages the undercut in the far zone in tooth supported RPDs, far zone, लेकिन जो अंडरकट डिस्टल एक्सटेंशन के पास होता है उसको बोलते हैं अंडरकट इन द नियर जोन. दैट कैन बी डन आइदर विद द हेल्प ऑफ रिवर्स सर्कुलेट क्लास्प और बैक एक्शन क्लास्प और इवन विद आरपीआई बार क्लास्प. अब क्योंकि इसमें ये दे नहीं रखा तो आरपीआई हम नहीं दे सकते, क्योंकि इंटीरियर अगर दे रखा होता तो इंटीरियर दे सकते. तो बेस्ट आंसर फॉर ऑल प्रैक्टिकल पर्पसेस यू टेक अ पोस्टीरियर अबटमेंट इज प्रेजेंट, फॉर एग्जांपल सेकंड प्रीमोलर व्हाट XYZ, नथिंग एल्स इज गिवन. तो बेस्ट आंसर हियर विल बी रिवर्स सर्कुलेट क्लास दैट एंगेजेस द अंडरकट इन द नियर जोन दैट इज नियर द edentulous ridge. Okay, do not give simple circulate clasp in case of distal extension cases. It's contraindicated. Why? Because it may overtalk the principal abutment in anterior posterior direction. Remember this. Clear? Last question. An edentulous patient with bilateral bony exostosis in tuberosity region visited NG for denture. Exostosis is 2 cm in size. What should be advised? देखो, अगर एक्सोस्टूसिस है इसका मतलब ये है कि हमारा कहीं ना कहीं अंडरकट क्रिएट हो रहा है ना, और दोनों साइड है। देखो आइडियली तो अब अगर तो अंडरकट बहुत बहुत ज़्यादा सिवियर है, ठीक है, एक्सोस्टूसिस का साइज मान लो फॉर 2 mm है, 2 सेंटीमीटर तो बहुत ज़्यादा हो गया। एक्सोस्टूसिस मान लो 2 mm बोनी एक्सोस्टूसिस है जिसकी वजह से अंडरकट क्रिएट हो रहा है, ठीक है। अगर 2 mm ही है इसका मतलब कम है, ठीक है। तो व्हाट वी डू इज हम जो एक बोनी अंडरकट को रिमूव कर देते हैं, तो हम एक बोनी अंडरकट को रिमूव करते हैं और दूसरे वाले को हम मेंटेन करते हैं। सॉफ्ट टिश्यू अंडरकट्स हैं, नो प्रॉब्लम, यू कैन मेंटेन बोथ। बट इफ दोनों बोनी अंडरकट्स हैं, अगर साइज दे रखा है एक छोटा एक बड़ा, तो बड़े वाले को सर्जिकली हटा दो, छोटे वाले को मेंटेन कर लो। लेकिन नहीं दे रखा है, कम दे रखा है, तो ऑलवेज रिमूव वन, मेंटेन वन, ठीक है। दूसरे वाले को मेंटेन क्यों करना होता है? वाई? बिकॉज वी नीड रिटेंशन, इट विल हेल्प इन रिटेंशन। दोनों को अगर हमने मेंटेन कर लिया तो बेटा फिर वो डेंजर, इट विल क्रिएट इंजरी, it will create problems for the patient. So we may remove one and save one. Any doubts? Any doubts? I'm waiting for a minute. I have completed all the questions. I hope you people have understood the topic, understood the questions of November and INICET. Any doubts? I'm waiting for 1 minute more. Kindly let me know. Any question you did not understand? अच्छा, मैं एक चीज़ और बता दूँ बेटा, कॉम्बिनेशन क्लास्प, write down combination clasp is given in distal extension cases where mesiobuccal undercut is to be engaged. लिख लो, normally we always engage the distobuccal undercut, but अगर distobuccal undercut नहीं है तो हम सिंपल सर्कुलर डिज़ाइन लेके, क्लास्प नहीं दे रहा हम, we combination clasp is what? Combination clasp is your wrought wire, retentive arm and cast chrome reciprocal arm. So in such cases where if we have to engage the mesiobuccal undercut, we can give a combination clasp. Embrasure clasp is given on the dentulous side. पूरा कॉम्प्लीमेंट है डेंचुलस साइड का। क्लासिफिकेशन मान लीजिए ये है, यहाँ पे देयर इज डिस्टल एक्सटेंशन और यहाँ पे पूरे दांत हैं, कोई मॉडिफिकेशन स्पेस नहीं है, तो हम वहाँ पे एम्ब्रेजर क्लास दे सकते हैं और मॉडिफाइड क्लिप क्लास दे सकते हैं ऑन दी dentulous side. Full complement of the teeth are present, there we can give an embrasure clasp. Difficult to seat, it may distort, we have to create spaces, create bevels on the buccal and the lingual side for embrasure clasp. Okay, I hope today's session was fruitful. I wish all the best for the exam that we are having in November, INICET. I hope these sessions that we people are taking in association with DAMS, we are DAMS faculty, we want all of you to prepare well and nothing should be left behind. So we are doing our sincere efforts. The faculty from Delhi Academy of Medical Sciences are doing our best so that you people can benefit the most. Thank you so much. Stay tuned for further lectures from DAMS. Thank you so much.